Good morning and welcome to the ENDO 2013 Clinical Trials Press Conference. We hope that you've been enjoying your ENDO experience. My name is Ann Coppola. I am a member of the Advocacy and Public Outreach Core Committee for the Endocrine Society and today's session moderator. I'm an endocrinologist and clinical researcher from the University of Pennsylvania where I study hormones and aging. Today we'll have a presentation of 3 trials, one in testosterone in women for verbal learning and memory, one on regulating circadian clock and blindness, and the third in testosterone in men for coping with pain. I would like to introduce you to today's presenters. We're pleased to have with us first Dr. Susan Davis, who is at the National Health and Medical Research Council, Principal Research Fellow, and Chair of Women's Health at Monash University in Melbourne, Australia. Followed by Dr. Stephen Lockley, Associate Professor of Medicine at Harvard Medical School and a neuroscientist in the Division of Sleep Medicine at Brigham and Women's Hospital. And we'll be concluding with Dr. Shahzad Bazaria, Medical Director of the Section of Men's Health, Aging, and Metabolism at Brigham and Women's Hospital and Associate Professor at Harvard Medical School. Over the next 25 minutes, each speaker will present their findings. Following all 3 of the presentations, we'll open the microphones for questions and answers. Please note that this news conference is being broadcast live via webcast and that there are many journalists with us online right now. Because we are broadcasting live via the web, it is important for all remarks to be made into a microphone to enable those who are joining us virtually to be able to hear what is being said in the room. Journalists who are attending online will be able to type in their questions during the question and answer period. We'll be starting with the questions for those present in the room, and then we will end with questions that will be read from those who are logging in online. I would now like to invite our first presenter, Dr. Davis, to the podium.
Thanks very much, Dr. Coppola. So it's an honor to have this research that we've been doing selected to talk to you about. Our work recent years has been involving testosterone in women. What people generally do not appreciate is that women, particularly in their reproductive years, at any point in time have more testosterone in their circulation than they have estradiol. So testosterone is an important hormone for women. It's important because testosterone is the building block from which estradiol is made, but it also acts independently throughout the body. So we know that increasingly that testosterone has effects not only on sexual function, which most of you would have heard about from other research, but also effects on muscle, bone, the cardiovascular system. We often think of testosterone as a nasty hormone for women, but in fact it dilates blood vessels, it has good effects on vascular function, it doesn't do nasty things to cholesterol and other lipids, and in fact it probably is essential for women to be healthy, not only in their bodies but also in their minds. Our group was the first group to show across the lifespan that testosterone declines in age in women. And this is a study we did several years ago where we showed that the greatest reduction in testosterone occurred in premenopausal women, usually between the ages about 20 and 40. So by the time the average woman has reached menopause, their testosterone levels are already about 50% lower than they were when they were in their 20s. And we have no idea why women have this decline in testosterone. We don't know what controls this. There's been increasing evidence that testosterone may have an important role in brain function, both in women and in men. Most of the research has been done in men. Now, we've done 2 earlier studies where we looked at the role of testosterone in cognitive performance. So when I talk about cognitive performance, I'm talking about the ability for somebody to perform on various tests, like learning lists of words or doing puzzles, getting through mazes on paper or on computers. And we found consistently in our 2 earlier studies that testosterone improved verbal learning and memory, even though we looked at a lot of other parameters. In our first study, which was a placebo-controlled trial, we used conventional tests of verbal learning and memory and other tests. And the problem with these tests is that they were mostly developed to look at people who have got cognitive deficit. They weren't developed to look at people like us who have normal cognitive function to see if we can change within the normal range. So we worked very hard to identify a robust means of measuring cognitive function in people who are performing normally in the community. In our first study, as I said, we used conventional tests and showed an improvement in verbal learning and memory. And in our second study, in a smaller cohort, using the robust measures, we also showed the same outcome. And we wanted to explore this further. So for this study, we conducted a double-blind, randomized, placebo-controlled trial in 96 postmenopausal women aged 55 to 65 years on no hormone therapy. The women were treated with a testosterone gel that contained testosterone or identical placebo for 6 months. The women underwent comprehensive testing of their cognitive performance at baseline, with the primary outcome being at 26 weeks, but we also looked at cognition at 12 weeks. That was a secondary analysis that if we found an outcome at 26 weeks, we could go back and look and see how early that change occurred. And our aim was primarily to see if we could see an improvement in cognitive performance, particularly looking at verbal learning and memory, because that's the outcome we had seen earlier. And the study was conducted at Monash University in our clinical trials unit. It was a single-centre study. And what we found is that women receiving the testosterone showed a significant improvement, specifically in verbal learning and memory, but in no other cognitive domains. Now, I show you this result on a full-scale graph. It would be very easy for me to cut the scale in half and make the outcome look dramatically greater. But we saw an improvement of 1.57 units. And this difference was relative to placebo. The improvement from baseline was actually greater, but the primary outcome was the difference from placebo. So it's significantly different, but does it mean anything? And in fact, it does. So using this test of cognition, the average person with mild to moderate cognitive impairment with Alzheimer's disease will have a loss of about 1.5 units on this test over 12 months. In addition, a new H2 receptor antagonist, which has undergone phase 2 studies, has been agreed to by the FDA to go on to phase 3 studies, and that H2 receptor antagonist shows a mean improvement of 1.5 units. So what we are seeing is a significant clinical improvement in cognitive function in women. Now, these women were not cognitively impaired, so what we hypothesize is that women after menopause or in this age group are not operating in their optimal cognitive range. And women commonly complain of loss of memory after menopause. And this is more optimizing normality rather than treating a disease. So I've mentioned this finding, and these are the references relative to the improvement we saw. So this is the third study in which we've seen the same domain of cognitive performance improve. And while, as I said, women could not be classified as being abnormal for their age, we have really seen an optimization. Not only have we seen this in 3 studies, but concurrently we conducted a study that was also a randomized placebo-controlled trial where we did exactly the same protocol, and women were randomized to estradiol and a progestin versus placebo. And in that study with estrogen progestin, so HRT, we saw no effect of cognition. So what we're seeing is a very specific testosterone effect, and it's very specific to verbal learning and memory. And I think that the evidence is robust, and what this means is it needs to be looked at further to see whether it would help women with mild cognitive impairment and whether it should be considered as a positive benefit for treatment for women as they get older. So thank you.
Thank you, Dr. Davis. I would now like to invite Dr. Lockley to the podium. And I have a couple things to say about the availability of his slides. So you'll be able to see them for the people in the room. You'll be able to see his slides. They are not going to be posted on the web. We're asking that no one take pictures of these slides, and they will not be distributed because of the proprietary nature of some of the slides.
Thank you. Good morning, everyone. Today I'd like to present briefly the results of 2 clinical trials to study the effect of tasimelteon to treat non-24-hour circadian rhythms in totally blind patients. These were sponsored clinical trials by Vanda Pharmaceuticals. The circadian pacemaker is located in the hypothalamus in the brain in an area called the suprachiasmatic nucleus. And this clock in the brain generates circadian rhythms with a period close to, but not exactly, 24 hours. The SCN controls the timing of many 24-hour rhythms in our physiology, behavior, and metabolism. And some of the common ones that are measured include the sleep-wake cycle, alertness and performance patterns, hormones such as melatonin and cortisol, body temperature, and many aspects of metabolism. The light-dark cycle resets this clock every day so that we can remain synchronized between the internal clock and the outside world. And light is the strongest time cue that synchronizes our clock. But in the absence of the ability to detect light, such as in patients who are totally blind or don't have eyes, the rhythm returns to its intrinsic period, its non-24-hour period, causing a disorder called non-24-hour sleep-wake disorder, but also disorders in a range of all the rhythms that the clock controls. And so melatonin, cortisol, performance, mood, and so on are all desynchronized from the outside world. So the first clinical trial was the SET study, which was a randomized clinical trial to test the efficacy of up to 6 months of 20 milligrams of tasimelteon treatment compared to placebo to entrain or synchronize the circadian clock to the 24-hour day. And then the second clinical trial was the RESET study, which then aimed to look at the impact of withdrawal of treatment in patients who had been entrained with tasimelteon during screening. So here's the SET study design. Patients were assessed for up to nearly 6 months in screening to confirm that they had a non-24-hour rhythm. And we did that by measuring a urinary metabolite of melatonin called 6-sulfatoxymelatonin. And we measure the peak timing of that hormone, and if the timing changes from week to week, it tells us that the clock is non-entrained. And so we confirmed the period, the circadian period of the clock prior to treatment, and then randomized patients to either 20 milligrams of tasimelteon or placebo, treated daily at 1 hour before a fixed bedtime. We asked patients to choose a 9-hour in-bed period for the entire study, and patients were given or asked to take the drug 1 hour before that time at the same clock time every day. And then we did a series of assessments throughout the 6-month trial, physical exams, blood tests, and so on, but it also included a clinical global impression of change assessment, where the clinician rated improvement or worsening of symptoms in the patient. So in the SET study, we had 27 US sites and 6 German sites. These were men and women aged 18 to 75 years with confirmed no perception of light and non-entrained urinary 6-sulfatoxymelatonin rhythms. And they also had to have a report of a sleep disruption in the past 3 months to enter the study. We randomized 42 patients to placebo and 42 patients to tasimelteon, and they were very similar in terms of their age, gender, and health. And the primary endpoint of the SET study was entrainment of the clock measured by 6-sulfatoxymelatonin. And then we also had a step-down primary endpoint, which is entrainment of the clock plus improvements in a range of clinical endpoints, which I'll review. And so the intent to treat analysis showed that 20% of patients given tasimelteon entrained according to their melatonin rhythms, whereas only 3% of placebo patients entrained. And in the clinical response, which is entrainment plus a range of functioning and sleep measures, 24% of patients were improved compared to no patients on placebo. And these were highly statistically significant. If we look here at 2 examples of patients, you can see, first of all, on the left-hand side, the tasimelteon-treated patients. You can see the non-24-hour timing of the melatonin rhythm shown here in the red stars, associated with a disruption of the sleep-wake cycle with episodes of relatively good sleep and no daytime naps, with then episodes of bad sleep as the internal body clock runs at a different time to the 24-hour world. And you can see here a similar pattern in those placebo patients. But first of all, in a patient here who was entrained with tasimelteon, you can see that the timing of the 6-sulfatoxymelatonin rhythm entrained to 24 hours. It now is no longer moving. It's at a fixed time each week. And associated with that, you can see a great deal of improvement in the sleep-wake cycle, where there's a much more consolidated sleep episode at night and very little sleep in the daytime, a remarkable difference compared to the screening data. In this example here of a patient who didn't entrain when given placebo treatment, you can see again the very similar timing of the sleep-wake disruption as the melatonin rhythm exhibits this non-24-hour period. And so three of the clinical measures that we had were the upper quartile of daytime sleep duration, so the worst quarter of the cycle of this cyclic sleep disorder. And patients receiving drug had a 46-minute per day reduction in daytime sleep, compared to only 18 minutes in placebo. And for the nighttime sleep, the worst quarter of nighttime sleep, patients had a 57-minute improvement in sleep per night, compared to only 16 minutes per night in the placebo group. The clinical global impression of change showed a significant improvement in investigator ratings of patient functioning over the entire study. In the RESET study, we entrained all the patients to tasimelteon treatment and then randomized withdrawal from the drug. 10 patients were continued on tasimelteon, whereas 10 patients were taken off drug and put on placebo. And then we assessed whether their clock remained entrained versus whether their clock reverted to a non-entrained, non-24-hour rhythm. And again, the primary endpoint was the proportion of non-entrained patients who changed when they were randomized to drug or placebo. And we found that only 1 out of 10 patients, only 10% of tasimelteon-treated patients reverted to their non-24-hour rhythm, whereas 8 out of 10, or 80% of the placebo-treated patients reverted to a non-24-hour rhythm. We had similar results for the timing of urinary cortisol, which is a secondary measure of the clock and tells us that, given that the melatonin and the cortisol rhythm changed in parallel, that we were affecting the central clock, the hypothalamic clock in the brain. Patients on placebo also relapsed in terms of their sleep symptoms, with a return to very poor nighttime sleep and daytime sleep after about 4 weeks of withdrawal from treatment. And here are 2 examples of patients who were entrained initially with drug, and in this patient on the left continued to be entrained when maintained on tasimelteon. You can see the sleep remains consolidated with very few daytime naps and good nighttime sleep. Whereas in the placebo group, when put on placebo after being entrained on tasimelteon, you can see that the sleep-wake disturbance returned very quickly with here a non-24-hour rhythm of 6-sulfatoxymelatonin and cortisol returning in placebo-treated patients. Again, the sleep disruption was significantly different between these groups. Patients put onto placebo had a 50-minute increase in daytime sleep during the worst quarter and had a 74-minute worsening of nighttime sleep when compared to their entrained baseline on drug. The overall entrainment rate for both of these clinical trials was around 50%. If we take all patients who were unique to either study and given drug, we find that approximately 50% of patients entrained on drug compared to placebo. But these data represent really the minimum entrainment rate, because in the first study we assessed their circadian period relatively early in the trial, and we anticipate that other patients will have entrained later, but we were unable to assess that. So in conclusion, tasimelteon entrains totally blind patients with non-entrained circadian rhythms. The overall entrainment rate for all people given drug was around 50%. Tasimelteon treatment significantly improved clinical ratings of global function, as well as measures of nighttime sleep and daytime sleep, and also sleep timing. We also assessed that, and that was improved with drug. Withdrawal of drug caused a decrease in nighttime sleep during the worst quarter of nights and an increase in daytime sleep, showing that maintenance of treatment is required to maintain circadian entrainment and maintain the clinical benefits of treatment. And the drug tasimelteon was safe and well tolerated in both studies. Thank you very much. So the next speaker is Dr. Passaria.
Thank you very much. I would like to thank Dr. Coppola for introducing us and the Endocrine Society for giving us this opportunity, and I would like to acknowledge Jenny for her work to schedule this meeting. I should mention that this study was funded by AbbVie Pharmaceuticals, and it was conducted as a single-center study at Boston University School of Medicine prior to a recent move to Brigham. So in background, opioid analgesics significantly suppress hypothalamic pituitary gonadal axis, with in some patients testosterone even declining into the castrate range. In animal models of castration, male mice or male rats, when they undergo castration or testicular removal, they experience more pain when they're introduced to noxious, painful stimuli. And that pain perception and pain tolerance is significantly improved once they are repleted with exogenous testosterone implants. At the same time, when you look at the population level data, women generally experience both acute and chronic pain to a disproportionately greater degree than men. All these data suggest that testosterone might have what we say antinociceptive or analgesic effect. However, this concept has never been tested in a double-blind randomized placebo-controlled trial, and that's what we set out to do. These are some data from population studies. If you look at the bar graph on the very left at the top, it shows prevalence of pain in the general population as divided as pain perception in men and women. And as you can see, if a woman and a man is asked what was your pain level or pain perception the day prior to the interview, women mentioned that their pain ratings were significantly higher than men on the previous day and also on the current day when they were interviewed. On the right side, we look at acute post-operative pain. These are men and women who are undergoing similar surgical procedures. Either it will be hip replacement or knee replacement. And after that procedure, post-operatively, pain perception is much higher in women as compared to men. And the last data which I'm showing at the bottom is musculoskeletal pain as perceived by people in the media. So this was a study on male media workers which was conducted in the morning hours. Testosterone levels were drawn and they were asked about what kind of or what rating of pain they have, with particular emphasis on musculoskeletal pain. And as you can see that men who felt more pain had lower testosterone level as compared to those media workers whose testosterone levels were higher. In terms of mechanism, this is a simplistic cartoon showing how opioid analgesics affect hypothalamic pituitary gonadal axis. The major effect of opioid analgesics is on the hypothalamus, and it decreases the hormone known as GnRH right at the top, which is secreted by the hypothalamus and creates a picture of central hypogonadism. But there are a small subset of patients in which the opioids directly affect the testes and decrease production at the testicular level and results in what we call primary hypogonadism. There is only one open-label pilot study which has been published in the literature conducted by Norm Mazur and Harry Daniel. These were 23 men who were all started on transdermal testosterone gel at a dose of 5 gram, and then after 3 weeks the dose was increased to 7.5 gram of gel. And the instrument they use is a similar instrument which we have used called BPI, or Brief Pain Inventory. It's a validated questionnaire to evaluate pain perception in the general population. And on the right bar graph, you do see that men who were on 7.5 milligrams per day, they did report improvement in pain perception. But I should emphasize this was an open label study in a very small number of patients. So we tried to answer this question in a double-blind randomized placebo-controlled trial. It was transdermal testosterone gel versus placebo for a total of 14 weeks. Men were 18 to 64 years old who had chronic non-cancer pain, and majority of men had back pain, pain in the limbs, and even headaches. They have to be on opioid analgesics for at least 4 weeks. The opioid dose cutoff was chosen as men who are on hydrocodone, 20 milligrams or higher every day, or any other opioid analgesic equivalent. And their entry criteria in terms of biochemical hypogonadism was total testosterone less than 350 nanograms per deciliter as measured by mass spectrometry, which is considered to be the gold standard. In terms of outcomes, the primary outcome was clinical pain perception, how patients feel based on BPI, or brief pain inventory. And secondary outcomes, which were novel, was quantitative sensory testing in a pain laboratory. These patients were subjected to mechanical pain, pressure pain, and temperature pain to see what their perception and tolerance is. Secondary outcomes also included quality of life measures as evaluated by SF-36 questionnaire. And also, we were interested in looking at what happens to their opioid analgesic dose at the end of the study as compared to baseline. To this effect, 84 men were randomized, 43 in the testosterone arm and 41 in the placebo arm. The starting dose of transdermal testosterone gel was 5 grams. 2 weeks post-randomization, there was a dose adjustment visit because our target range in the testosterone population was 500 to 1,000 nanograms per deciliter. And if dose increment was made in any subject in the testosterone arm, a sham dose increase was also performed in the placebo arm in order to maintain the blind. And our completer sample included 36 men in the testosterone arm and 29 men in the placebo arm. This is a glimpse into the instruments that we use in order to perform the quantitative sensory testing in the laboratory. On the left side, it is a ice water hand immersion machine where there is a water bath at 4 degrees centigrade where patients immerse their hand. And by the time they immerse their hand, a stopwatch starts to see for how many seconds they're able to keep their hand inside. The first perception of pain, or they report to you when they are feeling pain, and it's sort of recorded at what is the time period at that time, and there's first perception of pain, and also pain tolerance, that for how longer they can keep the hand inside and when they really have to pull it out. On the right side is an algometer which creates pressure. You apply this algometer either on the trapezius muscle or on the thumb, and you keep on applying pressure, which is measured in watts. And when patients mention to you that this is the time point they can't tolerate anymore, you stop and you record the number of watts of pressure applied. And finally, at the bottom, these are tools to apply mechanical pressure, which are applied on the volar surface of the forearm. There are different pins, as you can see, with blunt edges, which apply these pressures. And patients let you know what the ratings are of pain from 1 to 20. So these are the results. As expected, testosterone levels and free testosterone levels increased significantly in men who were randomized in the testosterone arm, as you can see in the blue bar graphs. This is our primary outcome, brief pain inventory on questionnaires. And as you can see that over time, pain perception or clinical pain perception declined in both groups, and it was not statistically significant. In terms of our secondary outcome, which is quantitative sensory testing, you see the mechanical probe test up on the top. On the left side is the first stimulus, and on the right, the 10th stimulus. And you can see the pain perception is much better or improved in the testosterone arm as compared to the placebo arm. The ratings of pain fell in the testosterone arm. In the lower bar plot on the left side, it is the pressure pain. And men in the testosterone group, as noted in the blue bar graph, were able to tolerate more pressure as compared to the placebo arm. And on the right side, there was sort of a trend that men were able to tolerate cold pain more who were in the testosterone arm as compared to placebo, but it did not reach statistical significance. In SF-36 and quality of life questionnaire, the role limitations due to emotional problems improved in the testosterone arm. There was a trend in terms of statistical significance. Other domains of quality of life did not improve. So in conclusion, testosterone administration in men with opioid-induced androgen deficiency was associated with an improvement in several measures of quantitative sensory testing. Subdomains of quality of life scale also improved and showed a trend in the testosterone arm. The end of study opioid requirements in the two groups did not change, data which I am not showing today, but it was part of the poster reported yesterday. So what do we make of this? Well, it appears from studies of analgesics in the general population, either non-steroidals or any other type of analgesics, quantitative sensory testing, improvement in those parameters usually precede improvement in clinical pain. So you are seeing that laboratory pain is improving, but clinical pain has not improved yet. And it is possible that our study was of a shorter duration. If we would have conducted study for a longer period of time, it is conceivable that our primary outcome, which is BPI, might have shown improvement as well. Thank you for your attention.
Thank you, Dr. Bassari. Thank all of you for your very clear presentations and for keeping us right on time. I'd now like to open the microphone up for questions and answers. Jenny is going to have a microphone that she'll pass around to you all. We'd like you to state your name and affiliation prior to answering the question, and kind of all discourse is going to go into the microphone from either end so that the people who are participating via web can hear everything that's going on. So, first question.
Hi, this question is for Dr. Lockley. I'm Barbara Boughton from Medscape. Can you tell us what the side effects of your drug are in the study?
So we had a very detailed assessment of side effects and adverse events, as you would expect in a clinical trial, and they are not significantly different from placebo. And some of the common side effects are nausea. Sometimes people in taking these drugs feel nausea, occasional headache, and of course sleepiness, which in some cases is desirable. Melatonin agonists will cause some sleepiness, which is why we gave the treatment an hour before their scheduled bedtime. They're the main side effects, but there were no differences between drug and placebo in these trials.
How common were the side effects?
These are in very single-digit percentages. They're very low levels.
Hi, I'm Sarah Allen from the Lancet Diabetes Endocrinology. I've got a question for Dr. Lockley. Lockley, did you find anything that defined your responders versus non-responders?
Not specifically. We did, in the inclusion criteria, limit patients who had a circadian period of 24.25 hours or longer, because there's some ambiguity in assessing the circadian clock in patients who have a period much closer to 24. We also, as you saw in one of the final slides, we did in a sensitivity analysis limit those patients who had a clock time or a clock period longer than 24.75. And that's because previous studies have shown that patients with a long circadian period are harder to entrain because you need a very powerful time cue to reset the clock in patients with a period much longer than 24 hours. And so those would be that would really be the main effect, the intrinsic clock. We haven't done any further analysis to understand if there's other predictors, although that will be an area of interest in the future.
Alex Otto, Clinical Endocrinology News. Dr. Lockley, I'm wondering what indication is being pursued for this medication. Do you have an idea yet?
So yes, on May 31st, Vanda filed to the FDA for treatment of non-24-hour sleep-wake disorder in totally blind patients. And so one of the symptoms I mentioned of a non-entrained clock are disorders of sleep-wake timing. Although this is not a sleep disorder per se, it's a disorder of the ability of the clock to entrain to the 24-hour day. As I mentioned at the start of the talk, many of the rhythms that are controlled by the clock are affected, and sleep is one of those that patients notice, but also the timing of melatonin, the timing of cortisol, mood, performance, anything that's really entrained by the clock. But the formal indication is non-24-hour sleep-wake disorder in totally blind patients.
Okay. And where in the development, phase 1, 2, 3, are we with this drug? Sorry if you said that already.
Sorry, so these are both phase 3 clinical trials, and the FDA filing occurred on May 31st. So it's been submitted.
Dr. Bazzaria, I'm wondering, it's very interesting information you have here. I see that you're sponsored by a company. Same question as to Dr. Lockley. Is there an idea of going after some type of special indication for this property?
Not at all. In fact, I should emphasize that diagnosis of hypogonadism and indications of treatment of men with testosterone should be the same as in any other population. In other words, I should say that there is no reason for men who have a pain disorder to initiate testosterone therapy solely for the purpose of improvement of pain. You should initiate treatment in this population like you do in any other patient who has signs and symptoms of hypogonadism and you have unequivocally diagnosed biochemical parameters of hypogonadism by checking testosterone levels. So this is just the first study showing potential anti-nociceptive effect of testosterone, but a larger study should be done, and at this point in time, one should not initiate treatment, testosterone treatment, solely for the purpose of pain improvement.
Okay. Dr. Davis, is there anyone else? Dr. Davis, the dose and dosing schedule of the testosterone in your gel?
We used the testosterone gel that the application was 220 micrograms per day, which, to put it in a ballpark, the Intrinsa patch was 300 micrograms. And it's been shown to put testosterone levels in other studies into the mid-normal female range. And the dosing is a once-a-day application of the gel.
Okay. So I'm sorry, I missed this in your talk. Were these women, did they have low testosterone initially?
We recruited women who were healthy women aged 55 to 65 who were interested in participating in the study. There was no requirement for them to have low testosterone. However, the mean testosterone at recruitment was at the lower limit of normal for total testosterone, but we didn't set out to have that in the population. And as I said, the level of testosterone declines with age. So by the time a woman is about 60, and the average age of the women in the study was about 57, the level's going to be low. It's unusual to have a mid-normal range compared to a premenopausal woman.
Sure. In the 1.57 unit improvement, what was that scale? Was that a 40-point scale? Did I see that slide right?
It was a 1.57 improvement in correct memory, a correct response to words, and the absolute scale, there are 16 words presented with each test times 3.
So that would be a 16, a scale of 16?
No, the scale is of correct words at 16 times 3, and I'm too tired to 48. 48.
So
Sorry.
I just want to
the
make
absolute
sure.
scale, to get it perfect, you'd have to get 48 words right.
Okay, so it's improving a 1.57 on an absolute
Scale of 48.
Great, thank you. And you mentioned an H2 receptor agonist. What was that receptor agonist?
It's a GK something. It's nothing we've got anything to do with, but it's. I put the reference up on the slide. It's Nathan and others as the author of the paper that's published the outcome, but I think it's GSK or GK 5164 or something like that. It doesn't have a name yet.
That's sufficient. And my last question is, we're all familiar with the Women's Health Initiative, and is there any concern with giving hormones to women in this age group about, potential side effects like we saw in that trial? Of course, that was, female hormones, but these are still hormones.
Yeah, people always are concerned about hormones. The literature for testosterone now is actually quite vast. The largest study that's been conducted is the Aphrodite study, which I was the first author of for the New England Journal, and that was 800 women randomized to 2 different doses of testosterone or placebo. That was conducted for 2 years, and that and other studies, and those women were not on hormones, on estrogen, and that and other studies of women on estrogen haven't shown any significant adverse effects in terms of cardiovascular events, perturbations of lipids, insulin resistance, carbohydrate changes. We did a 20-year retrospective review of the rate of breast cancer and other cancers in women in Australia treated with testosterone, and another group have done similarly and found no increase in breast cancer risk.
With testosterone?
Yeah.
How about cardiovascular health?
There's never been a study that has shown that. We've done several studies looking at that. We did a study where we gave acutely inhaled testosterone, so you've got rapid increases in levels. And what you see is an acute vasodilation, so blood pressure drops about between 5 and 10 millimetres of mercury. So testosterone's been shown to actually have salutary properties in women if used in the right window of therapy. Now, clearly, if you're going to give women supraphysiological doses of testosterone, you're going to get adverse events. But the cumulative data has not shown anything sinister. And if you look at the use of testosterone, it's actually been around for decades. Our FDA equivalent's the TGA, and we've checked with the TGA about adverse event reporting of any use of compounded other testosterone that's been used in Australia. We've used implants for 3 decades, and there are actually no adverse events.
And Doctor, a final question. You've shown this benefit. What's the end game here? Is this a company effort or anything like that? Where is this going to lead? What do you envision if this holds up with additional testing, your findings?
Well, the end game for me personally is that I've tried to understand for the last 30 years what testosterone does in women, since there's so much. And it doesn't matter if you look at upside down or sideways, there seems to be multiple benefits for normalising testosterone in women who are truly deplete, particularly if you look at women with hypogonadism, and possibly there's a benefit for older women. So I think the end game is understanding physiology, and if we are going to move the goalposts, and the average female girl born in, certainly in Australia today, has a life expectancy of 102 years, we need to, and cognitive decline is one of the major issues we're going to have with the ageing population. I think we need to understand what we can do to perhaps preserve cognition rather than necessarily treat cognitive decline. So we need to prevent decline before it happens rather than worry about treating it when it happens. So there's possibly a beneficial effect, but it does need to be explored. Do I have a company agenda? No. We had to really grovel to get this study funded. It was heavily funded by the Mason Trust, which is a trust that funds cognitive dementia studies in Australia, NHMRC, and we got the study drug from Biosante, and they gave us some very basic funding which really covered minimal costs of the study, but there's no drug company agenda here.
Okay, thank you.
Do we have any questions from online, Jenny? No, we don't? Okay, great. Well, thank you all for coming. It's been a great press conference, and enjoy the rest of the meeting.